Thank you. I'm Elena Rios, President and CEO of the National Hispanic Medical Association. We're very honored to be here with our 23rd annual conference, this year co-hosted with the Hispanic Dental Association. Thank you for being here. Welcome to Washington. Before we start, I just wanted to have the board of directors, especially our chairwoman, Judy Flores, our chairman of our foundation, Mark Diaz, and all the board members. Can you please all stand up? We also have in the audience our Council of Young Physicians, our Council of Residents, Latino Medical Student Association, and partners who are presidents of Hispanic medical societies and Hispanic health professional associations around the country. Can you please stand up? Any of the leaders here? Well, I know there's some. If some of you are here, yes, come on. I know a lot of them come for our gala tomorrow night. And I want to really thank our platinum sponsor, Centene. And I saw Joyce and Centene Company. Are you here? There you are. Thank you very much for underwriting the event. We have other sponsors. I just want to thank our top sponsors, Abbott, AbbVie, Lilly, the National Hispanic Health Foundation, the All of Us Research Program, Amgen, CDC's Act Against AIDS program, Pharma, Pfizer, Ultimed, Care First, DaVita, Intercept, and Sanofi. And all of the rest of you that are here, I know that I'm especially interested in telling you a little bit more and thanking the Cancer Treatment Centers of America today. It gives me great pleasure, and I'm going to just show a few slides so you can see NHMA. So you all know that Latinos in this country, in the United States, are here to stay, and actually it's projected, right now we're 57 million people in this country, the largest ethnic group, and we're projected to be 1 out of 4 Americans in our lifetime in the next 20 years. Just to show you where we live, everywhere. And especially in the Southwest, since we were Mexico before the United States decided to buy Mexico. The demographics of the country, just to put it in perspective, yellow in every region of this country is the growth rate of the Hispanic population. Orange is everybody else. Guess what? We're growing 3 times more than everybody else. And it's really because of our fertility rates, not so much immigration. Social determinants of health. I'm just going to put a few slides about some of the most important foundations for Latino health policy. We've been in Washington trying to explain why we need Latino health policy. Why? Because we come from poor income neighborhoods and families. This generation of physicians who started this organization in 1993, we are from the middle class of the United States, and we know what it means to be from these communities. So when you look at social determinants, you have to look at housing, food security, transportation, financial literacy, education, employment, homeless, prison experience, and immigration status. We also know you have to look at patient-centered care. You cannot have, now that we know about the triple aim and about the importance of coordinated care, et cetera, we have to look at patient-centered care. In our communities, we have to look at family-centered care, aftercare and home services, target care to the most in need, have care coordination, not only in the hospital, but outside, long-term care and home health care. We need to teach families and caregivers about self-management so that we can decrease the emergency room visits. We need to increase behavioral health, value-based care, reimbursement for all of the providers, decrease costs in care, increase lifestyle behavior change, and there is a real need for Latino research on all of these issues so that we can develop effective measures for our programs of Medicaid and Medicare and all the programs that pay for health care. So who are we? In 1994, I was working at the White House in 93, and a few of us realized that this country couldn't find us. They didn't know where to find Hispanic doctors. They thought we were all in gangs and working in factories. So we decided to show ourselves and create an organization called the National Hispanic Medical Association, a nonprofit 501c6 that now represents 50,000 licensed Hispanic physicians in the United States. Our vision is to be the premier organization that improves the health of Hispanics and other underserved, and our mission has always been to really empower our Latinos, and not only Hispanic doctors, but Latino serving doctors who take care of our communities in the community clinics, and in the safety net hospitals and academic institutions, and work with all of our partners. And we also established our own foundation called the National Hispanic Health Foundation. We have a board of directors from all across the country led by Dr. Judy Flores, who's from New York. And I'm not going to go over this, but I just wanted to say that we are representing the nation. Our NHHF board of directors also, more research-focused oriented board. And we have advisors, including Henry Cisneros, Dr. Richard Carmona, a past Surgeon General, Dr. Richard Zapanta from Los Angeles, Yasmin Winkler, the highest-ranking Latina within the United Health Group, and Ron Estrada from Univision. We have a corporate advisory board, and we have a leadership council. And what do? We serve as a resource. We develop leadership, and we develop networking opportunities. How do we do this? By millions of things, but the most important, I think, are some of our congressional briefings to educate the younger and younger staff on Capitol Hill about who we are and what our issues are. We nominate our members to HHS's advisory committees and grant review committees. We develop private sector technical assistance just to help with programs and even marketing of new products for some of the pharma companies. We have leadership development programs, and we have networking opportunities. I'm not going to go over these, but just say we have national conferences, regional conferences, and especially networking events just to meet each other and support each other. In terms of our network in 2018 and 2019, sorry about the typo there, this is our network. We not only represent physicians, but we have a national Hispanic health professional leadership network. And you have to, for the dentists in the room, I want to thank you for being a part of our networks. Since 2004, we have given awards to the presidents or leaders of the network of Hispanic health professionals in this country. No other Hispanic organization honors the leadership and the time and effort and volunteering to keep our organizations going, whether we're dentists or nurses or physician assistants. And I'm going to tell you, we're very proud that we just started the National Hispanic Pharmacists Association over the last 2 years. And of course, the students. Our advocacy has focused on access to care, the Affordable Care Act especially, and Medicaid and CHIP and clinics and the class standards, prevention with HIV, work with CDC, immunizations, obesity, cholesterol, medical education, at all levels, and research on Latino health and value-based payment. Our summits have brought together physicians, community leaders, and policymakers. Our STEM summit in 2013 to get more pre-med out of the STEM pipelines in high schools and colleges. Our Alliance of Multicultural Physicians worked with NIH on a summit on leadership and diversity in research. Our Medical Spanish Summit just last year has provided information about why we need medical Spanish in medical schools. And our cardiovascular summits, now we have a cholesterol campaign to raise awareness about cholesterol and as a risk factor for heart disease. And our congressional briefings. We have a coalition, we belong to a lot of different coalitions, and we do education. And education is leadership development, research, and scholarships. We give scholarships with the Hispanic dentists, with the Hispanic nurses, with the Latino Caucus of the American Public Health Association, and now with the National Hispanic Pharmacists Association. They all select the students, we get the funding and develop the logistics. And lastly, we have a new campaign. I'm actually the chairperson of a Hispanic Advisory Council to the Cancer Treatment Centers of America. And we have a campaign called the No Esperes campaign. Cancer is the #1 cause of death among Latinos. 1 in 3 Latinos in their lifetime will be diagnosed with cancer. This is a movement to get more of us providers to tell patients to get tested and screened. And we believe that it's so important that we have just requested a resolution. I want to thank our Government Affairs Office and Pedro and others who helped us get to the Congressional Hispanic Caucus just in the last few weeks. We've met with Congressman Joaquin Castro, who is now the chairman, and we have a resolution that was, it hasn't been approved yet, but we've submitted it. There is 1 week in the United States, in the healthcare weeks of the country, called Minority Cancer Awareness Week, and we've asked for the Tuesday of that week to be National Latino Cancer Day. So I just want to show a brief video. It's a 1-minute video, 2-minute video.
When that guy stands before me, he goes, hey, okay, we got our test back. And he says to me like this, that tumor you have on your tongue, Mr. Nunez, is called squamous cell cancer. Immediately when he told me it was squamous cell cancer, my wife could tell you that from these eyes, it looked like Niagara Falls. It's a shame, because I'm a happy-go-lucky guy. If you get to know Hector Nunez, I'm a real happy guy. I love people. I like to talk to people. And I was just so scared. And he said, today, I want to tell you this. He said, you are cancer-free. And I remember when I opened my mouth for the first time to sing to the congregation. And I picked up that mic, and I go, they say something like this, go, ¿Qué dirán la gente si me ven cambiado? Y notan que las cosas que yo hacía no las hago. ¿Qué dirán si no ven mi rostro amargado, el cual reflejaba cuando era un esclavo? When I opened my mouth, my friend, with that salsa music in the back, and I was swinging to this, and I don't get tired of telling people about my story.
So thank you. We're very proud to be involved in campaigns that educate our community to be healthier, and in this case, to get tested and screened for cancer. So with that, let me bring up our next welcoming speaker, Dr. Manuel Cordero, the Executive Director and CEO of the Hispanic Dental Association.
Good morning. It's really an honor and a privilege to be here with you. And I'm really inspired by you, Dr. Rios. What you have done is exemplary. And together, we're going to move mountains. This is just the beginning. So I am the new Executive Director and CEO of the Hispanic Dental Association, but I come from a long history of serving general dentists through my association with the Academy of General Dentistry, which is the largest organization of general dentists in the world, and it's actually based in this country. And it has made me who I am and has changed the way I see the world. Because, by the way, this last video is very appropriate, because general dentists are the #1 individual that is going to detect early signs of oral cancer. Oral cancer early detection is critical for the survival of the patient. And as part of our approach in medicine, prevention is all we talk about. By the way, most, if not all, of the oral conditions are preventable. Cancer is not preventable. but it is able to be treated to a positive conclusion thanks to early detection. So the collaboration between dentistry and medicine, which is what we represent in this meeting today, is not only historic, but it's critical that we continue educating each other for the sake of our own patients and for the community that we treat, which is not only the Hispanic community. That is our main focus, but we are all educators and caretakers of the US population in general. We have special needs in the Hispanic community, and that's why we exist, because we want to make sure that we take care of those special needs of the Hispanics and other underserved communities. But this collaboration is much bigger than just our communities. It's the country that we serve. I am now leading this group of Hispanic dentists that are not only educators, but clinicians, researchers. We also include in our association, by the way, hygienists, dental assistants, and any other individual that is concerned or gets involved in caring for our communities. We are very inclusive. When we started the collaboration with the National Hispanic Medical Association, it's a natural fit because medicine and dentistry belong together in order for us to be truly effective interceptors of health. Oral health leads to systemic health. One thing does not. You cannot have one without the other, is basically what I want you to walk away with from this meeting. We have representation, like I said, from all those other fields in dentistry. And we have a collaboration with other groups, like the National Dental Association, the Society of Dental American Indians, and again, trying to become inclusive, because if we don't have providers for this cultural sensitive part of the population, we're not achieving our goals. And our goals right now is to serve not only the profession, but the future leaders into dentistry and medicine so that we have more caretakers with the special skill sets that we represent. Education, collaboration, and unity is the message that I want to bring to this group, and we're going to walk out of here much stronger than when we came in, with each other's help. Thank you very much for welcoming us, and if I can be of any help, please approach me. I'm in the area. Thank you. Thank you. Thank you very much.
Thank you. Now it gives me great pleasure to bring our federal leaders up to the stage, and our first speaker and our keynote speaker is Admiral Brett Gerard, who is our Assistant Secretary for Health at HHS.
Thank you very much, Dr. Rios. It really is an honor to be here, and I got so jazzed by the first part of this meeting. There are about 20 topics that you talked about that I would love to talk about: the social determinants of health, prevention of cancer, particularly oropharyngeal cancer with HPV vaccination. By the way, my office is kicking off a major national HPV campaign this coming week. So many things that we can talk about, but I've been asked to speak about two topics that I am leading at HHS, and that is the response to the opioid and substance use epidemic and the intersection with HIV and our new initiative to end HIV in America. So I'm just going to speak for about 15 minutes. I'm a pediatric critical care physician, by the way. I trained at Parkland. I ran Children's Medical Center in Dallas. Yay, pediatrics, right? So I really try to bring a lot of that patient-centered approach to whatever I do. And whenever we talk about numbers, all of you who are physicians or dentists, we talk about numbers, but we see the patients. We see their families. We see the impact on their communities. And I think that's why it's so important that physicians and dentists like you are advocating on the Hill and everywhere else, because you really know what really matters in keeping the patients in mind. So give a few minutes, and I'm going to open it up to questions for 10 or 15 minutes before I have to run, and that's probably the most important part. So can I get the slides, please? So thank you again. So I think all of us understand at this point in time, we may not have understood 10 years ago, but the opioid use epidemic and the substance use epidemic is the most critical public health issue of our time. And by the way, all these slides are available to you. You can have them afterwards. Take pictures if you want, but you could have the slides, use them, teach with them, tell your students, teach your communities. The latest data we have based on household surveys, about 70,000 household surveys, suggested that 11.4 million people in this country misuse opioids in the past year. About 2.1 million have the use disorder or are addicted to opioids in the common terms. 53%, this is still in 2017, obtained the last pain reliever they misused from a friend or relative. That's why it's so important that we limit opioid prescriptions to just what the patient needs. Don't give them 60 days supplies because they sit in the medicine cabinet and grandma or brother or the son takes them and they become addicted, and then this whole vicious cycle starts. And very importantly, and I think we all know that, is 62% of people misuse opioids because they have pain. If we do not solve the pain crisis in the United States, how to treat pain more effectively, more holistically, more with integrated pain management, we will never solve the opioid crisis. The numbers are staggering. Now, you will see all kinds of numbers about how many people are affected, but the end of the year numbers, which are the official ones that you see, the last ones that we button up are from 2017. So it's amazing that 7,000 people died of overdoses in the US in 2017, and about 47,600 of those were due to opioids. And I'll talk about what they really are. If you're 18 to 35 years old in the United States, 20% of all mortality is associated with opioids. That's a staggering number. When you look at what's causing the opioid deaths, you see really three different waves. And it's going to be hard for me to point, but if you look at the orange line, this is natural and semi-synthetics. These are the pills. So this is the OxyContin, this is the very potent opioids that were prescribed. They really started the epidemic very early around the year 2000 with a gradual increase. I'll show you that that's really going down. The second wave of the epidemic is in blue. That's due to heroin deaths. And what happened as we started decreasing prescription of prescription opioids, and there were more and more restrictions on them, unfortunately, treatment for people who are addicted were not coupled with the decrease in opioids. So what do? They turn to heroin on the streets. And we have to understand, and we all understand here, that addiction is a disease, and you can't turn it on and off. If I can ask you to stop breathing for 15 minutes and you can do that, then I can ask a person whose brain chemistry is completely changed to stop using opioids, but you can't. So if you cut off the prescription, they're going to go to whatever they can get, and that's heroin. The third wave is what we're in right now, and that's yellow, and that's the due to the transnational, primarily from China, importation of fentanyl, which we all know is a highly potent opioid that's usually restricted in any of our hospitals. As an intensivist at a children's hospital, only an intensivist or an anesthesiologist could use fentanyl because of it's so potent. Now we have hundreds of pounds of it hitting the street. That's gotten into the heroin supply. It's actually gotten into the methamphetamine, cocaine supply. It's even in some marijuana that we're seeing. So that's caused that wave. So right now, when we talk about the opioid epidemic, it really is the third wave, which is fentanyl. Now, the latest data we have, now this was all back to 2017. This is overdose mortality data that's reported every month by the CDC, and it's 6 months behind, because it takes about 6 months to get the actual causes of death so that we have 99.5% of all deaths. And what we're seeing, so the last data we have, we're seeing that the heroin, the pills, prescription overdoses, and methadone are going down. And very, very importantly and very good. So heroin down 5%, pill deaths down almost 12%, methadone is still a small amount, but the synthetic opioids, fentanyl, are still going up. They're going up less quickly than they were before, but I want to bring everyone's attention to cocaine and psychostimulants, which is methamphetamine. And I'm going to talk to you a little bit more about that because I think we're entering the fourth wave of this crisis, and that is from fentanyl to more methamphetamine. And if you're living in a number of states, particularly in the West, the methamphetamine deaths are now overtaking the fentanyl deaths. As an example, this is the deaths from psychostimulants or methamphetamine in California compared to fentanyl. Now, if you take all the opioids still kill more people, but we talk a lot about fentanyl and we emphasize it, but in California, there's 4 times the deaths due to methamphetamine than there is to fentanyl. So one of the issues that I'm trying to raise right now, and you'll see lots of policy changes, is we can't just focus on one drug and one type. We have to focus on the entire problem, and again, the social determinants of health and all the factors that lead people into substance use to begin with. That's where we really need to be. So at HHS, very broadly, we have a 5-point strategy. If you really want to geek out, we have 73 sub-strategies under this. We can give you the link, over 600 programs, but in general, they all come under 5 different banners. Number 1, better addiction prevention, treatment, and recovery services, and that is really key. Because addiction is a disease, people need therapy, it needs to be for long term, it's a chronic relapsing disease, and that's the way we have to approach it. And if you dissociate the decrease in opioid prescriptions from treatment, you're only going to push people into heroin or fentanyl, and you're going to have more deaths. So it's absolutely critical to have treatment available nationwide in every community, urban, rural, for young, old, as we decrease the opioid supply that's coming into the country. Better data, this is really the CDC working on getting us more timely data so we know where the epidemic is. Better pain management, very importantly, to use opioids only as needed and not overprescribed. There's so many young people here, and you won't relate to this, but people in my age group, you could not let a patient out of the hospital with any pain. Your reimbursement was tied to it, your quality indicators were tied to it, the lack of pain was a human right. We were taught that opioids for pain were not addictive, and that's all completely wrong. Thank goodness the tide has turned. We're much more evidence-based now, so better pain management. Overdose reversing drugs like Narcan, naloxone, I think all of you know that. Very, very important. Doesn't solve the addiction crisis, but it does give a person a second chance. And better research. I just want to highlight a couple things. Number 1, how are we doing with opioid prescribing? And this is basically the medical profession policing itself, using more evidence-based guidelines and doing the right thing. So morphine milligram equivalence is just it's a metric to talk about what is the quantity of opioid. So if you have a highly potent opioid, it counts more as an MME. So just since 2017, we're down 27% across the country in opioid prescribing. That is really terrific. And we need to continue to be careful that we don't not prescribe for people who really need it, such as those with cancer, or I'm so pleased about your talks coming up about sickle cell disease, which is a major topic within our office to really impact sickle cell disease. So we have to preserve pain management for those who need it. But decreasing the opioid prescribing is absolutely a positive trend. Evidence-based treatment. We talk about 4 different components. Number 1, medication-assisted therapy. That is the most important component. Not the only component, but it's the most important one. There are 3 classes of drugs. Naltrexone, which is once a month injectable, long-acting, complete antagonist. Buprenorphine, usually with naloxone or Suboxone, which can be prescribed by anyone with a waiver to do so. It requires 8 hours of training, but that's being opened up quite a bit. Or methadone, which can only be done in opioid treatment programs. With that, if you had the optimum therapy, you had psychosocial therapies like contingency management or cognitive behavioral therapy. Very important recovery services. This is why we work with all the community organizations, faith-based organizations, housing organizations, education organizations, because if you take a person who's addicted and you throw them back out on the street with no housing, no employment, no education, they're going to go right back. So really working with the faith-based communities and all the social support is important, and naloxone. So I pulled these data last week because there's a lot of discussion like only 20% of people are getting MAT. We've done a lot better than that. So if you really look, if there's 2.1 million people with opioid use disorder, some of them will have mild disease and may not need MAT. Some of them will refuse MAT. But if you look at the latest data we have, over 1.1 million people are getting MAT. The majority of that is buprenorphine, but a lot of people, about 381,000, are getting methadone. And those are old data, but the latest one we have, so it's probably much more than that. So we are actually doing pretty well with that. Narcan, people have done great with that. We're up over 760% in distribution. These are the number of 2-dose packets that were distributed in 2018. And you see it's well over 4.4 million 2-dose packets, so over 8 1.8 million doses have been distributed throughout the country. So people are doing a really good job with that. We are seeing results that are positive. This is the latest data we have on non-fatal overdoses, and I'll just point to the big graph. For all drugs, we're down about 7% coming to emergency rooms, and for opioids, we're down about almost 15%. And this is a curve that you will not see because everybody looks back to 2017, the final data. But what this is every month we calculate a rolling 12-month mortality. So what has been the overdose deaths within the 12 months, the months ending at those months. And of course, there's a PowerPoint glitch, so it turned into gobbledygook on the bottom instead of dates, because this happens frequently. But if you look at that curve, you see that our overdoses have gone up. They peaked in about October of 2017, and we're starting to come back down on the other curve. So not that we've won this at all yet. We were clearly moving in the right direction because of everyone's work, and we have to continue our efforts incredibly strongly in the future. Priorities, just to make a couple comments. Number one, we're going to directly address the resurgence of methamphetamines and cocaine. So we need to continue to focus on fentanyl, but we can't ignore methamphetamines and cocaine, which are surging, particularly in the West. There's going to be a healing community study. This is going to be announced April 18th, and many of you may be there. There are going to be 4 states involved, at least 15 jurisdictions in each state. It's going to be a $360 million program to really integrate everything at the local level, and that's very exciting. We're transitioning from a crisis framework into an integrated sustainable framework, like models of how we can better take care of individuals through care delivery partnerships. This is the MOMS model that does integrated care for mothers who may have substance use disorder in impacting the big act called the Support Act. A couple of other priorities is, number one, we're very supportive of syringe services programs. Syringe services programs are very important to channel people into recovery, but also to reduce HIV and HCV. And if you're in a state that's yellow, there are laws prohibiting that. This is an evidence-based practice that we really want to try to get into as many states as possible. We have to work on how to transition people from an emergency room, from an overdose, into a treatment program. And finally, the criminal justice system is a really, really important point. One of the highest rates of mortality is when a person exits criminal justice system because they've been in the criminal justice system, they're off opioids. If they're not on MAT, when they go back on the street, they take a dose, that dose that they've been taking for a long time, but they're now naive and they die. So the rates of death coming in and out of criminal justice system is just horrendous, so we're going to work on that. The last couple of slides, and I may be 2 minutes over here, is that what are we doing with HIV? So it was shocking to me as I was preparing to get confirmed for this job that we still have about 40,000 new cases of HIV every year in this country. And there's really no reason for us to have that. About 10% of them are due to IV drugs use, and about 2/3 of them are men who have sex with men, and about 1/4 of them are heterosexual transmission. But this is today in America when we have all the ability to prevent HIV. As you might expect, African Americans and Latinos, Hispanics, have much higher rates of HIV than their population, as well as American Indians and Alaska Natives. And it's focused primarily in the South. 52% of new cases are in the South. The time now is really right to have an initiative like the one we proposed, and there are really 4 reasons. Number one is the epidemiology. 50% of new cases of HIV occur in only 48 counties. That's really remarkable. So if you can do a public health effort on those 48 counties and really pour resources there, you can really tip the scales of the outbreak, then move to the other counties and eliminate the disease. Second, antiretroviral therapy. I'm old enough that when patients first of all, there was in 1980s, there was no drugs. You had a diagnosis of HIV, AIDS, you were going to be dead within months. There was really nothing we can do. Then the early antiretroviral therapies, and if you remember, 20, 30 pills a day, every 4 hours, 6 hours, with water, without water, with food, without food. Now we're down to 1 pill per day. Highly effective, and in most patients you can achieve absolute zero virus. If you're in care and you take your therapy and you achieve 0 virus, your life expectancy is now 70 years old. The problem is 1 in 3 patients take at least 5 years to be diagnosed. 1 in 7 take at least 7 years to be diagnosed. So people are not getting therapy. Pre-exposure prophylaxis. Not only can you have behavioral changes to limit, but we now have Truvada or PrEP, which is about 97% effective in decreasing transmission. And finally, we have models of care, like the Ryan White program that has been very effective. It's very holistic. It not only provides drugs, it provides housing and transportation and all the things we need. So the program we announced will reduce HIV new infections by 75% within 5 years. It doesn't show very well, but those dots are the 48 hotspots around the country that we're going to focus the program on, as well as 7 states that have a high rural burden. Because we don't just want to focus in the urban areas, we do want to attack the rural issues, particularly in Indian country and in the South, which are fundamentally different problems than we have in the middle of major cities like Atlanta or Baton Rouge or New Orleans. We are now having listening sessions, and we're allocating $30 million that will be out within the next month or two to support community pilot programs. So they will build their plans ready to achieve the money for next year. And I don't want to go into this, but we have in the President's budget about $291 million of new money to start the initiative, which is really important because, as you know, the President's budget cuts everything by about 9 or 10%. So to have an extra $300 million here is really very important. With that, I will just end by saying both of these initiatives can only be done with a whole of society approach. We cannot solve the opioid use, behavioral health issues in our country. We cannot solve the HIV crisis just by being physicians or just by being the federal government. We need the people who are living with the diseases. We need tribal organizations, faith-based organizations, community organizations all working together. And I hope this opens up a conversation that we could build in the future. Again, I know very short remarks, wanted to give you an overview of these 2 programs, and I'd be happy to take questions for the next 10 or 15 minutes. Happy to answer, and again, thank you for inviting me. It's a real pleasure. I think you have microphones up here, so I was told you could just come to the microphones and ask your questions.
Any questions, please? Please identify yourself and just make a brief question.
Okay, my name's Tommy Harrison. I'm a general dentist from Katy, Texas. I'm on the program tomorrow at noon. I'm also chair of the American Dental Political Action Committee. I loved your presentation, and I've heard many of them, but the way you presented it, condensed it down. I really like that PowerPoint. You mentioned that. How do we get that?
We will provide it to the organization.
Yeah, we'll send it to everybody that registered.
Great, thanks.
And Lauren will take care of that. So,
Thanks.
Yes.
Mm-hmm.
Good morning.
Oh, yes, ma'am.
Yes.
Okay. I'm looking to the other side of the room. Sorry.
It's okay. So my name is Cheryl Lee, and I'm a general dentist in Washington, D.C. I was looking at that slide with the 48 counties.
Yes.
And, of course, I'm trying to remember all of the geography with a no map
Washington,
line.
D.C. is part of that. Washington, D.C. and San Juan. So 48 counties, Washington, D.C. and San Juan.
And that big clump up towards the northeast, was that the New York area, or was that?
There is, we have, I think we have posted a list of that.
Oh.
But they're the major metropolitan areas, of
Okay.
course, that you're going to see. Here, Baltimore, there's 3 areas in Maryland and D.C. that we're going to be focused on, again, in the Northeast, but a lot of areas in the South.
Yeah.
And we're focusing, broadly, but the South has 52% of the cases. They have the least infrastructure to approach the problem, and the problems of stigma of entering treatment are very much worse in the South. So you will see us focusing everywhere, of course, but particularly focused on places around Atlanta, which have 4 jurisdictions that are there, Baton Rouge and New Orleans, and really the Deep South, where the problems in Mississippi and Alabama of reaching primarily young African-American men who have sex with men, given the stigma and the lack of structure, is really a big challenge.
Right.
So you'll see an enormous amount of effort in the South, but all the way through the country.
Thank you.
Over here, Dr. V Hill.
Yes, sir.
Yeah, my name is Pablo V Hill from Albuquerque, New Mexico, and I'd like to just make a comment and a question.
Sure.
We know that alcohol, the prohibition of alcohol never worked. In the 1920s, It was prohibited, but then we had to make it legal again. And I feel that the same thing applies to the illegal drugs, cocaine, heroin, methamphetamines. We have to regulate it and legalize it is what I feel. What do you think?
We do not support legalization of those drugs. Methamphetamine, cocaine have no medical use, and they're highly deadly. So we certainly support the appropriate use of opioids. And again, we've been very transparent about the fact that we want to have more research with things like marijuana. If there is a medical study that shows that a particular component of marijuana is helpful for anything, we will approve it. I'm the scheduling authority for the country. I get to schedule it. But absent a medical reason, these are highly deadly drugs, and you're not going to get support for legalization of those.
Yeah,
here.
but what about taking the criminality element out of it? That's
So
very important.
You'll be surprised to hear it from from a Republican administration, but we are trying to move heavily against the criminal paradigm for all of these, and that's why we're supporting drug courts to move people out of the criminal justice system and into the public health system and treat this like a disease. And I think the sentencing reform is very important. We have a lot of people, particularly minorities, who get very long sentences for small amounts of substance use with arrests. So we are trying to transition from a criminal prosecution to a public health, with the exception if you smuggle 100 pounds of fentanyl over the border and you are really that transnational cartel, we are highly enforcing those laws and with criminal penalties. But for a person with the disorder, we're treating it as a disease. Yes, sir. Yes, sir.
Hi, Luis Estevez. I'm a former chairman of the board, and I also wear another hat. I'm a vice chair of a drug-free rehabilitation program in New York City, based in Harlem. And I applaud the fact that there's going to be an increase in funding, but to be honest, we haven't seen it.
You haven't seen what?
The increase in funding, and we treat all of the target populations, the young adults, those who are recently incarcerated, and homeless women and children. So, I'd just like to get some insight as to how can we tap into that.
So this is both the mechanism and the problem, right? So there's a tremendous amount of funding that's going out, but they're generally, the funds are generally transmitted to a single state authority. So your state health department or your state mental illness or mental health organization. So, we put out an extra $1.5 billion of awards. The problem is you linking with your state. Okay, so we do not provide, in general, community-specific awards or program-specific awards. So this is a state issue with communication and application, and we're happy to talk to you about that with your state, particularly SAMHSA, but we get the money to the states, and the states manage those programs, like the substance abuse block grants.
Hey, thank you for that, but with all due respect, I think that's a weak link in the chain. Thank you.
It's a weak link, but it is a policy issue that we have to talk about, because we at the federal government would be very hard to pick all the individual organizations, 1,000 organizations in each state. And I'm not arguing with him, just saying there's a trade-off. So what we've chosen to do is provide the states large amounts of money that they could use on any evidence-based programs, and we're trying to believe that the states are more in touch with organizations. But I understand there's often a disconnect between the state and organizations like yours. I do understand that, and we're looking for ways to improve that. Yes, ma'am.
Good morning, doctor. Thank you for being here. My name is Lorraine Gutierrez. I'm in the trenches in a family practice in a community clinic in San Diego, California.
Yes, ma'am. Thank you.
So the question I have for you, number one, just a slight comment. This opioid crisis is one topic that really gets me steaming, because I'm old enough to remember when we were all required to get additional CME in pain management.
Right.
And we were conditioned to think that this was something that people could have no pain. So now, X years amount later, we're all dealing with the crisis. So that's the comment. Number one. Number two, in California, and until recently, it was a voluntary kind of a thing. If you were going to prescribe opiates, you had to look on the cures, something we call cures, to see where that patient had been getting their prescriptions in California. What I found over the years is a lot of people would skip the border, go into Arizona or New Mexico or whatever, and there I was getting medical release forms for people getting their opiates somewhere else. Is there any thought about creating a mandatory national registry for people like me to be able to look people up and see where they've been getting their drugs and how often and when?
So this is another one of these positions that 48 states have PDMPs, 48 states. 47 of them have the same system. They're completely interoperable. This is a state issue about how they want to share data with the other states. So it's not a federal issue. I guess the federal government could mandate something, but it would be very difficult because the state medical organizations and the state boards of medical examiner and everything control the data. So what you're seeing now, and this is growing, is that states are getting agreements with the states around them. So you will see more and more, and I don't know what California has, but particularly Ohio, Kentucky, Tennessee, they all have agreements, so they all share their data. But this is an issue with your state legislature about how they want to share the data across. We're seeing much better trends, but that's where to point, because it's a state issue.
Thank you. It'll be time to write a letter. Thank you.
Write a letter, but
Yeah.
you're seeing that there is a move to have more of a national database, that the CDC is funding that. So if we provide a lot of funds to states to do their PDMPs, there's now a position that if you're going to take CDC money, you have to participate in another sort of mirrored national database. So we're trying to move there because people have not shared, and the other issue is the 48 states are all under a proprietary database, and the company who owns it is now jacking up the costs for sharing. As you might imagine, you have a monopoly on it. Now if you want to share, the costs go up. So we're trying to, this year, provide another route for states to go in. Yes, sir.
Hi, Francisco Fernandez from the Rio Grande Valley.
Yes, sir.
And I applaud all your efforts, all those ongoing efforts from past administrations as well as the new ones. I wonder if you have a concern. As a psychiatrist, I read every day and journals about legalizing ketamine.
Legalizing what?
Ketamine, legalizing or approval of ketamine, let's say, MDMA, psilocybin, and the list goes on, living better through chemistry, for PTSD, autism, treatment-resistant depression, all major psychiatric disorders that need attention. But is there any attention focused on this process of these clinical trials and the impact that it'll have in society once these get approved?
So I don't run the FDA, and you know that, but I'll make a couple of comments, is that particularly Scott Gottlieb, when he's the recent commissioner who just left, is very cognizant of those issues. I think if you look at ketamine, which was approved, there was a lot of debate about that, but it is a remarkable drug for treatment-resistant depression that can have an effect within only a few days. Mm-hmm. The clinical data that shows the life-saving ability of that is telling. I think you'll see most of the discussion about approval of new opioids. That's where it will focus. Do we need more opioids? Do we need more potent opioids? Or we really need to cut off that at the FDA level? That really is an ongoing policy debate. There are issues, on both sides of that. Drugs like Disuvia, which is the sufentanil that was just approved, that was really approved for military medicine. Because if you're on the battlefield and you can't get an IV and you've just got your leg blown off, you need very acute pain medication. So I would say yes, we are very cognizant of the overall effects. That's why we have advisory committees as well providing input, and you'll see more and more of that in the equation, but your point is very well taken.
Yeah, I'm sorry, we're going to have to wrap this up. I know Nellie has reminded me about the speakers for women's health. We do have one speaker that did not show, so we have one more speaker from our federal leadership, Dr. Cara James, and I just want to have a round of applause for the Admiral and the Assistant Secretary of Health.
Thank you.
Thank you very much. Cara, you can come up. Cara James is the Director of the Office of Minority Health from the Centers for Medicare and Medicaid Services, and she's been with us before and has an update on CMS's great work.
Thank you. Good morning, and it's always great to be here. And I thank Dr. Rios for inviting me, and as well, I'm really excited that the National Hispanic Dental Association is also part of this conference, because as we know, your mouth really is the window into your health. And just to give a little bit of background, I don't have a lot of time to talk today. I know there's a full agenda, but wanted to highlight a number of the activities that CMS has underway, and to talk specifically about some of the things that we're doing within the Office of Minority Health at CMS to support that work. So one of the things that is particularly of interest for many of you, I'm sure, and hopefully some of you participated in some of the listening sessions that we've had, but as you know, our administrator has been very focused on patients over paperwork and burden reduction, and we've had a number of efforts to reduce that burden for providers. Some of the things related to documentation for those who are training residents to account for that, as well as other reductions in quality measures, so that we are focusing on meaningful measures, less on process, more on outcomes. Some of the other things that we're doing, and Dr. Gerard just mentioned the work on opioids, but we are continuing to expand our innovation efforts. And so we've announced 2 recent models, the INC model to focus on maternal behavioral health issues and substance use for women who are pregnant, as well as our KIDS model that's looking at behavioral health needs for children and others. And then we're hearing a lot of conversation around the social determinants of health. So some of you may be participating in our Accountable Health Communities model, which is one of the first models that's really looking at the linkage between social determinants of health and health outcomes in the Medicare and Medicaid population. And we are continuing to engage our stakeholders across the spectrum through listening sessions, as well as other opportunities for feedback, soliciting requests for information through our rulemaking and other spaces. And then one of the areas that I'm helping to co-lead is we're rethinking rural. So rural health is an area that has garnered a lot of attention across the country and growing. And as we're thinking about, how the intersection of rural Hispanic health and other communities, rural communities relative to urban communities from the 2000 to 2010 census did not grow as rapidly, but the growth that did happen in rural communities was largely driven by Hispanic and Asian Americans, Native Hawaiians, and Pacific Islanders. So we're seeing greater diversity that's happening there, and making sure that we're paying attention to those needs is critically important. And just one example, when we think about the intersection between rural and opioids, we know that the opioid epidemic has been harder hit in rural communities. And you saw the slide that Dr. Giroir put up about MAT and access to some of those services through OTPs. Unfortunately, only 10% of the OTPs are in rural communities. So one of the things that we're working on is to think about how we can help to expand those to increase access to the services that are needed. So in the last couple of minutes that I have, I wanted to just talk a little bit about the CMS Office of Minority Health, in part to just let you know that for all the things that are happening across CMS, we can be a bridge to help get questions answered, to help triage you to the places and connect you with some of the many things that are going on. So you can go to our website, which is go.cms.gov/OMH. You can learn more about what we're doing. You can also find contact information for us. So if you're seeing something CMS is doing X, Y, and Z, and you have a question, we can help get you to the right place and work on that. The other thing is to let you know that there are numerous offices of minority health across HHS. So there are offices within each of the agencies. There's one, Dr. Collins reports to Dr. Giroir in the OASH, the Office of the Assistant Secretary of Health, but SAMHSA, HRSA, FDA, CMS, CDC, AHRQ, NIH, all have offices of minority health, as well as the FDA as well. In our office, we focus on our path to equity through three things. We call it our USA framework. We're working to increase our understanding and awareness of disparities and their causes, to develop and disseminate solutions, and to implement sustainable action through ourselves and our partners. So really, we don't want it to be viewed as that work that's being done by that office over there, but how do we make it part of standard operating procedure, working on the priorities that the agency is focusing on? And we think about this at every level, from our policy down to our beneficiaries. So in the data space, in terms of increasing our understanding and awareness, we've created some data tools, such as our Mapping Medicare Disparities tool that allows you to look down to the county level at outcomes for utilization, prevalence, costs, hospitalizations, all sorts of things related to health outcomes, and to compare across disparities populations. A few months ago, we've added data related to hospital quality, so you can see how hospitals perform mapped out relative to other hospitals, such as critical access hospitals, pediatric specialty, cancer specialty hospitals as well. So that's the HEDIS and CAPS data that is included, that we do as part of our STAR ratings. You can now view that on our website through the Mapping Medicare Disparities tool. We also produce contract level data for our Medicare Advantage HEDIS and CAPS plans that comes out. We do that every April for National Minority Health Month, so stay tuned as our new report is coming shortly. But it allows you to look at, as I said, the contract level, to compare how plans are performing across racial and ethnic populations. And we recently in November added one for rural and urban. We have quite a number of activities working for understanding beneficiaries with limited English proficiency. So we've provided a report and analysis of the individuals who are applying through the health insurance exchanges in the marketplace to understand what the top languages are and what the preferences for preferred spoken and written language. We've also looked at our Medicare patients and have developed tools such as a guide to implementing a language access plan that can help address some of the needs for individuals with limited English proficiency. We also surveyed providers to ask them about what they were doing and how many patients they felt they were serving that had language access needs, and what the organizations was doing. And the short of it is there's a lot of opportunity for improvement. So we have been developing some of the tools for that. We also are looking at the social determinants of health. And so a lot of people are engaging in this space now when we think about where you live, learn, work, and play, and the factors associated with that. But we're not doing standardized data collection. And if you've seen some of the reports that came out of the National Academy of Medicine for social risk factors, there are some places where we actually don't have great data for some indicators, and don't know really well the relationship between those indicators and their health outcomes. So we are looking at how we can encourage some of that standardization of data collection, as well as how we can help bridge to the supports that are needed to address those. When you think about oral health almost as a social determinant of health, we have so many older adults who have none of their natural teeth. The relationship, as we know, between oral health and job satisfaction, job ability to get a job, as well as health outcomes, and miss work because of mouth and oral problems is really a big issue. Unfortunately, Medicare does not cover dental services, and that is a problem, but that is a statutory change that would need to happen. In our area of developing solutions, one of the primary things that we have is a portfolio of work we call building the business case for health equity. And so we have a number of resources that include how we can help to capture data on individuals who are sexual and gender minorities and other vulnerable populations, our guide to developing the language access plan. We have a guide for reducing disparities in readmissions that focuses on how we can reduce racial and ethnic disparities there, and a number of other tools that we continually add to. Later this year, as we celebrate the anniversary of the American with Disabilities Act, we're going to be releasing some resources to help serve patients who have disabilities better. And I heard earlier from Dr. Rios that, Centene is one of your partners, and we're very pleased that we awarded Centene our Health Equity Award this year for their efforts to improve physical accessibility for their members through a grant program that they instituted following an analysis that they did of physical accessibility problems, where they provided resources to increase the facilities, building ramps, signage, other sorts of equipment to make it easier for patients with disabilities to access their care. So we're very pleased with that. The other thing you may have heard about, and is something we've been doing for a couple of years but continue to add resources, is our From Coverage to Care initiative. And this is to help consumers connect to care and understand their coverage to be able to use primary care and preventive care services primarily. We worked with SAMHSA's Office of Behavioral Health Equity to recently release a roadmap in behavioral health to help people understand that, have translated that into Spanish, and particularly we're serving that and sharing that for individuals who were affected by the hurricanes last year and the year before. And then lastly, from providers' perspective, we have a connected care campaign. We know so many of our communities have multiple chronic conditions, and then this is a services that are available for providers to bill Medicare for treating and care management related to patients with multiple chronic conditions. So we've had a lot of interest in that. That continues to be something that we did in partnership with the Federal Office of Rural Health Policy, focusing on rural as well as racial and ethnic minority beneficiaries and providers, and those resources are available and the codes that you can use to do that. And in the space of rural health, we released our CMS Rural Health Strategy. So I co-chair our CMS Rural Health Council, and that's one of the things that we have been doing a lot of effort in that. We are going to be having a convening in June focused on access to maternal health services in rural communities with an eye towards as well disparities, because we've seen over 100 hospitals have closed in rural communities, many more have closed their OB departments, and so women in rural communities are having to drive long distances. These closures have disproportionately affected communities of color in rural communities, so that's part of what we're going to be looking at and thinking about what we can do collectively. If you are interested in doing something within your organization, provider group, whatever, we also offer technical assistance. So we have health equity technical assistance through our office. You can reach out to us, again, at our website, go.cms.gov, and learn more about that. And we continue as well to engage with stakeholders. So as we're thinking about implementing sustainable action, we want to engage with our stakeholders. We've been working on the Accountable Health Communities model. We're looking at the 12th statement of work for the QIO program to embed a focus on health equity there. And one of the other things that we're really pleased about, for those of you who may have seen the Medicare Advantage call letter that just recently came out, as we're thinking about opioids, Dr. Gerard mentioned we want to make sure that those populations for whom it is appropriate for them to be utilizing opioids still have access. So we've been doing analysis of utilization among beneficiaries with sickle cell disease, and in the call letter, one of the things that you'll see is that there's a suggestion that maybe we consider exempting sickle cell patients the way we do cancer and hospice from some of the edits that we have. So how we think about making sure we can maintain access to them. So with that, I'm going to stop because I know you guys are running a little bit behind, but thank you again so much for having me, and look forward to it.
Okay, we're going to bring up our women's health experts, and Dr. Diana Ramos, our board member and public health official from California, is coming up to introduce them. And if you can all come up and have a seat up here.
I think actually we're going to call you up at the end for questions. So good morning, buenos dias. Please stand up, get some oxygen flowing. I know the coffee may not be kicking in now, it's wearing out. Okay, big stretch. So now that you're energized, I think, for one of the most important sessions, which is women's health, I hope that you're going to be as excited to learn about the fantastic information that we have to share. The one thing I want to do is I want to start out by bringing attention to the Women's Preventive Service Initiative. This handout was in your bags that you all received, and this is a gold mine. And so why do I say that? If you open it up, if you have a woman in your life, if she's an adolescent, a reproductive age woman, perimenopausal, postmenopausal woman, a woman in your life, this is your handbook. Why? Because this is a compilation, it's a well-woman chart of what physical exams, what component of a physical exam should be done depending upon, or what is recommended to be done depending upon the age of a woman. It also includes prenatal as well as postpartum recommendations. The most important, and I think the best part of this, is that this was done as a collaborative initiative led through ACOG, the American College of OBGYNs, and it is really a compilation and a multi-practice effort from the American Family Association, the American College of Physicians, the the Nursing Association. So it really is not just the American College of OBGYN, but it is a cross-collaborative effort. So please look at this. Anything that is covered by the Women's Preventive Service Initiative is covered as an essential health benefit. That means that it is available without a copay to your patients. So the Women's Preventive Service Initiative right now is actually working on billing codes so that you can bill for these. It's wonderful to do the right thing. It's even better when you do the right thing and you get paid for it. So I bring the attention to this. So let me get started, and I want to start out by thanking Dr. Nelly Correa for being a visionary on this panel. She was the one that said we really need to focus on women's health because women are the core of our Latino population, our families, right? We drive the healthcare, not only in the Latino population, but in healthcare decisions as well. So it gives me great honor to bring up and introduce our panelists. The first panelist is Dr. Tiffany McNair, MD, MPH, and she is going to be speaking to us on improving maternal health in the U.S. Dr. McNair is the Director, Division of Healthy Start and Perinatal Services, Bureau of Maternal and Child Health, Resources and Services Administration for the U.S. Department of Health and Human Services. She is at HRSA. Some of her key programs include not only the Healthy Start Initiative, which is a grant providing over $100 million in funding to improve perinatal outcomes and reduce racial and ethnic disparities in infant mortality, as well as the Alliance for Innovation on Maternal Health, a partnership to combat maternal mortality and severe morbidity, and through the design and implementation of evidence-based maternal safety bundles. And she also is the lead for the Women's Preventive Service Initiative. So the handout that you are in your bags that I spoke about, that is sponsored by HRSA, she oversees this. Prior to her tenure at HRSA, Dr. McNair was a division director and medical officer within the Prevention and Population Health Group at the Center for Medicare and Medicaid Innovation, also known as CMS. And before joining CMS, she was a White House fellow. And in that capacity, she served as a policy advisor and public health consultant to the Vice President of the United States, providing guidance and technical assistance to the White House advisor against violence against women. Dr. McNair graduated from Harvard College and received her MD from Harvard Medical School and MPH from Johns Hopkins Bloomberg School of Public Health. Please help me welcome her.
Thank you, Dr. Ramos, for that very warm introduction. And good morning, everyone. It's great to be here. I really appreciate this opportunity to be a part of this panel on women's health. And I hope that I'm able to do everything. I'm not as tech savvy as I'd like to be. So as an OBGYN and a preventive medicine physician, as well as a public health practitioner, I really am grateful to serve in support of what I'm sure is a shared pursuit in this room, and that's to achieve healthy and thriving communities, particularly among the most vulnerable under our care. And now I really do want to kind of take the conversation a little bit further by specifically focusing on the advancement of health and well-being among women, children, and families through the work that we're doing in the Maternal and Child Health Bureau at the Health Resources and Services Administration, which we also call HRSA. So our main objectives in the short time that I have with you today are first to provide an overview of the Bureau for those of you who may not be as familiar. Then I'd like to briefly discuss some of our key investments to improve maternal health, including our burgeoning portfolio on reducing maternal mortality and severe maternal morbidity. And then perhaps most importantly, I'd like to hopefully inspire your future engagement in these efforts to improve the health of women. And by extension, we know that if we're doing that for women, then we're doing that for children, for families, and for our communities. And then I look forward to the dialogue that we'll have following the panel. So the Bureau is housed within HRSA, as I described, and is one of the operating divisions in the Department of Health and Human Services. You heard from Dr. James, from CMS, also FDA, CDC, et cetera. And the Bureau is really one place within the government that is responsible for improving the health of all of America's mothers, children, and families, as you can see, for our mission. And it's through this mission that we envision America where all women, all children, and all families are healthy and thriving and have the opportunity to reach their full potential. So the Maternal Child Health Bureau represents approximately 11% of HRSA's budget and also has 11 different legislative authorities. Today, what I'm going to do is focus on our three largest investments, which are at the top. The first one is the Maternal and Child Health Block Grant, which represents approximately half of our budget and includes an allocation to states as well as discretionary set-asides for special projects of regional significance, and I will talk a little bit about that later on. And then about 30% of our budget is for the Maternal, Infant, and Early Childhood Home Visiting Program. Some of you may have heard of that, also called MCV. And then lastly, about 10% of our budget goes to the Healthy Start Initiative. The remainder of our investments are in 8 categorical program areas, which cover a wide range of topics that seek to tackle crucial issues surrounding maternal and child health, but they do have a slightly more limited budget. So I'll start with the Title V Maternal and Child Health Services Block Grant. With the passing of the Social Security Act in 1935, the federal government through Title V pledged its support to state efforts to extend the health and welfare services for mothers and children across the country. Currently, the Title V Maternal and Child Health Services Block Grant, which we affectionately refer to as Title V, is the public health system for women and children in the country, and it is actually the oldest federal-state partnership. As the Bureau's largest investment, Title V funds 59 states and jurisdictions to provide health care and public health services to reach an estimated 56 million people. This includes 86% of all pregnant women, 99% of all children, of all infants, and 55% of all children, and this includes children with special health care needs. So 2 hallmarks of the block grant to states include its flexibility and the accountability associated with it. The block grant format gives states flexibility in the use of their Title V funds that they receive to address the unique needs of populations served. But there are a few key requirements. First, states must spend at least 30% of their federal funds on children and youth, and this includes youth and children with special health care needs, and then at least 30% on preventive and primary care services for children. Every 5 years, states are also required by law to do a comprehensive needs assessment, including to identify the needs of mothers, children, and families. And then based on this needs assessment, they identify 7 to 10 priority needs, which will inform the development of a 5-year action plan. The Bureau ensures state accountability through our technical assistance and our performance measurement. Specifically, states are required to report a variety of measures across 5 population domains, and one of those domains is for women's health and maternal health. And that helps to assure continued progress through key national and state goals. So it's in that vein, as you can see here, there are 15 national performance measures across these 5 population domains. And of the 15, 4 relate to women's and maternal health explicitly. That includes the Well Woman Visit, low-risk cesarean deliveries, preventive dental visits during pregnancy, and smoking during pregnancy. What we're going to do is talk a little bit more on the next slide about the relationship between these measures and the action plans that states develop and implement to address the unique needs and priorities. So the program uses a 3-tiered performance framework. The national outcome measures are really sentinel indicators of maternal and child health, and then the national performance measures are more intermediate measures that influence those outcome measures. States also develop evidence-based and informed strategy measures for each performance measure. So let's just break this down and take an example of maternal mortality or severe maternal morbidity as a national outcome measure. Clearly, we know this is an important indicator of maternal and child health in our population. But what we don't want to do is wait until we tragically experience a maternal death to find out whether we're actually on the right track to making progress on this indicator. So what happens is states will look at measures that are related to maternal mortality and that are predictive of the outcome. For example, access to well woman visits, rates of smoking in pregnancy, and frequency of low-risk cesarean deliveries. And then what they do is we take it one step further. As part of their accountability, states then submit an annual action plan and describe what steps they will take to address key priorities that are tied back to the performance measures and to the national outcome measure. I've listed here a few examples of evidence-based strategies that are being implemented in states across the country, including increasing referrals to quit lines for mothers that are smoking during pregnancy, and also promoting quality improvement initiatives, like the implementation of maternal safety bundles in response to obstetric emergencies. So there's much more to tell and to learn about Title V than I actually do have time to share today, but if you're interested, you can visit the Title V information system, and I've included the website here for you, which is available to you online, and allows you to get both a national level overview as well as state-specific snapshots on their maternal and child health activities. Before I move on to the McV program, I do want to highlight just one other project under Title V's Special Projects of Regional and National Significance, also known as SPRANs. Funding under SPRANs aims to address critical and emerging issues facing the maternal and child health population, as well as promote collaborative learning to spread best practices. And one key example of a SPRANs activity that's related to maternal and child oral health is the Center for Oral Health Systems Integration and Improvement, also known as COSI. In 2017, the Bureau funded the National Maternal and Child Oral Health Resource Center at Georgetown University to administer the COSI project. COSI works with key stakeholders to improve systems and care in support of a quality improvement, patient-centered framework to address the oral health needs of the maternal and child health population. And as you can see on the slide, the consortium does have multiple partners of which you may be familiar, and they have three main goals. The first is to provide Title V recipients with technical assistance and training. The second is to identify maternal and child health, oral health quality indicators to monitor specific systems of care. And then the third is to develop and disseminate resources to professionals that are working in or with Title V agencies. So now I want to turn to the Maternal, Infant, and Early Childhood Home Visiting Program, again also known as MCV. The MCV program was established under the Affordable Care Act and is administered in conjunction with the Administration for Children and Families. As the second largest investment in the Bureau, it was created to support voluntary, evidence-based home visiting services for at-risk pregnant and parenting women and for young children through kindergarten entry. McV builds upon decades of evidence surrounding home visiting, which I hope many of you are familiar with, and this involves trained professionals like nurses, social workers, who meet with families in their home to identify and address critical needs to advance the health and wellness, particularly to improve maternal and child health outcomes, including positive parenting, school readiness, and building economic self-sufficiency. States, territories, and tribal entities receive funding through the McV program and are the driving force behind it. And here I'm just showing you the geographic reach and scope. There are grantees in every state across the nation in which more than 150,000 parents and children have been served, and over 930,000 home visits are conducted, and this was in the last fiscal year alone. As with Title V, states design their program based on a needs assessment, and they do have flexibility to tailor their programs, again, to the unique needs of their communities. They're also able to choose from 18 evidence-based home visiting models. Some of you may have heard of Nurse-Family Partnership, for instance, which is geared towards first-time moms. And this, again, is to best fit the community's needs, the capacity, and the resources. Now, McV does outline populations that are prioritized as being the most vulnerable. This includes low-income communities, adolescent, pregnant, and parenting girls, families with a history of substance use, of violence, and other adverse experiences. And in 2018 alone, over 70% of families served within the McV program were less than 100% below the federal poverty level. Over 75% relied on Medicaid or CHIP, and over 13%, or excuse me, approximately 13% of newly enrolled participants were pregnant teens. And then finally, over 2/3 of the participants belonged to racial and ethnic minority groups. This included those from Black, Hispanic, Latino, and American Indian and Alaska Native communities. As you can see, the grantees have provided 5.2 million home visits over the last 7 years. So I'm sure you're all asking yourselves, but really, how is the program doing? So from its inception, McV has adapted a learning approach that focuses research and evaluation efforts on improving program effectiveness and building on the existing knowledge base that I described earlier. As you can see here, there are 6 benchmark areas with corresponding measures. And while at the top you'll see maternal and newborn health is a specific benchmark category, I think we all know that all of these areas ultimately impact the health of women and children. In 2018, all states and all but 1 territory showed improvements in 4 out of 6 of these benchmark measures. And just to give you a few examples of ways that McV is serving families, 78% of caregivers were screened for depression, and 82% were screened for intimate partner violence soon after their enrollment, while 70% of children had family members that read to them daily. And all of these are really key indicators as we think about improving and sustaining improvement in the health of women and children. So next, I want to move to the Healthy Start Initiative, Eliminating Disparities in Perinatal Health, also known as Healthy Start, and which happens to be a program within my division. Really proud of this program. And it is the 3rd largest investment in the Bureau. The purpose of the Healthy Start program is to improve health outcomes before, during, and after pregnancy. And you heard Dr. Ramos share this, to reduce racial and ethnic disparities in rates of adverse perinatal outcomes, particularly infant mortality. And to do this, the program provides grants totaling over $100 million to high-risk communities with infant mortality rates at least 1.5 times the US national average, as well as high rates of other poor perinatal outcomes, low birth weight, preterm birth, maternal mortality, and severe maternal morbidity. Grantees do include public and private entities, as well as faith-based, community-based, and tribal organizations. Now, Healthy Start funding supports implementation of community-based interventions to support some of the most vulnerable women, children, and families in our nation. And there's a number of goals that are intertwined with this. It's to strengthen the health workforce in caring for such populations. It's to build more effective and efficient service delivery systems. And perhaps most importantly, it's to promote and improve health equity across the participating organizations. I note here on this slide the program's scope in 2017. However, we are really excited that we just announced a new cohort of Healthy Start grantees for the next 5-year cycle, and this was just announced at the end of last month. I've shown you a map of that new group of grantees. And as you can see, the geographic diversity is vast. And we're excited to share that among the 100 healthy sites in this round, that the reach extends to Puerto Rico for the first time. On that note, I will mention that HRSA, some of you may know this, HRSA previously did set aside funding for border Alaska and Hawaii projects in our past funding cycles. This was also known as the Border Initiative. This was set aside from general population grants in recognition of the disparities that do exist along the US-Mexico border. And while that is no longer a specific initiative that we have in this current cycle of grantees, our commitment remains strong to advancing the efforts of Healthy Start programs that serve Hispanic, Latino women, children, and families without limitations in terms of geographic location, particularly given that we know that in many cases, Healthy Start programs represent the only available and trusted source of care to reach some of these families. So Healthy Start's presence in highly vulnerable communities, such as among racial and ethnic minorities, not only serves to improve maternal and child health, but I would argue also strengthens family resilience and helps us to move the needle on overall collective impact. So let me briefly share some of our work surrounding the reduction and ultimately the prevention of maternal mortality. As many of us know, the rate of maternal mortality and severe maternal morbidity is rising, with approximately 700 women dying in the US annually from pregnancy or delivery complications. Moreover, the US now has a higher maternal death rate than many other high-resource countries. The most common conditions include those that are listed, but I do want to emphasize, especially given what we've heard earlier today, it's important to note that mental and behavioral health conditions, including opioid use disorder, are now leading causes of maternal mortality in many states. In addition, disparities do exist along racial and ethnic as well as geographic lines. So Black women being 3 to 4 times higher than white women to die compared to white women of maternal mortality and severe maternal morbidity. And also, medically underserved areas such as rural communities have higher rates of maternal mortality. We also know that 60% of pregnancy-related deaths are preventable. So improving maternal health outcomes and access to quality maternity care services is central to our mission, and reducing the U.S. maternal mortality rate is a top priority in support of this mission. I'll just highlight a few key endeavors that are underway in the Bureau to combat maternal mortality. First, we are catalyzing quality improvement in maternal safety, and I mentioned some of this a little bit earlier. This is through the Alliance for Innovation on Maternal Health, or AIM. This is funded through the Title V SPRANS funds, again, special projects for regional and national significance. And it's a national data-driven quality improvement initiative that's based on proven implementation approaches to improving maternal safety in hospital settings. AIM works through state teams and health systems to align national, state, and local quality improvement efforts to improve overall maternal health outcomes, and often are working in conjunction with some of the regional perinatal quality collaboratives. AIM is now working in 23 states, and there's some others that are in the pipeline, and has implemented maternal safety bundles in more than 1,000 birthing facilities across the country, reaching nearly 2 million annual births, or around half of all annual births in the US. Our maternity bundles, which you can find on the website, range from a focus on obstetric hemorrhage to hypertensive disorders in pregnancy, and also to reducing peripartum racial disparities. Another lever for combating maternal mortality has been the convening of global experts to share best practices, to problem solve, and to plan strategic solutions to addressing maternal mortality and severe maternal morbidity. So in June of last year, we held a maternal mortality summit at HRSA that convened experts worldwide to share these innovative strategies. Leading subject matter experts hailed from the US, from Brazil, from Canada, from Finland, India, Rwanda, and the United Kingdom, as well as representatives from the World Health Organization. And in the course of this convening, experts developed recommendations on a wide range of issues that impacted maternal mortality, everything from access to care, quality improvement, workforce development, data needs, the utilization of a life course approach, which we know is really important. We can't divorce maternal health from child health and all the way through a woman's entire life. And then improving the quality and consistency of maternal mortality review committees in states across the country. So finally, as we look ahead to expanding our reach related to maternal mortality reduction, we're excited about a new appropriation for this fiscal year, 2019, which has included additional funding provided to expand the Alliance for Innovation on Maternal Health that I described to all US states, the District of Columbia, and US territories, as well as tribal entities. We also have a new state maternal health innovation grants that will support state-led demonstrations to implement evidence-based interventions that will address critical gaps in maternal care service delivery. And then finally, within the Healthy Start program that I described, we have a funding increase of $12 million that will support the hiring of clinical service providers who will provide direct well-woman care and access to maternity care services in Healthy Start sites across the US. So as I close, I'd like to just briefly highlight how we are advancing maternal and child health as a bureau through our promotion of diversity among those on the front lines, like all of you. As I mentioned, improving workforce development was a critical finding in the maternal mortality summit that we had last summer. And the Bureau is focused on creating and nurturing a pipeline of talented professionals that tackle all of these issues that I've described today. HRSA's maternal and child health training programs have a particular focus on recruiting trainees from diverse populations and disadvantaged backgrounds, including Hispanic, Latino, healthcare, and public health professionals. In fiscal year 16, these data come from that, approximately 10% of medium and long-term trainees were identified as Hispanic or Latino. And just to give you a sense for what that means, medium or long-term, the term refers to the number of contact hours or the intensity of exposure to the training. So the medium is 40 to 299 hours, whereas the long-term is 300 plus hours. So you can think of the long-term as equating essentially to a full-time fellowship for those who participated. I should also note that participating clinicians were able to receive continuing education credits through this. The Bureau also supports 2 training programs, the MCH Pipeline Program and the MCH Catalyst Program, which report even higher percentages of Hispanic and Latino trainees. The Pipeline Program recruits undergraduate students from economically and educationally disadvantaged backgrounds to promote their inclusion in maternal and child health professions. And the Catalyst Program provides exposure to maternal and child health arena to graduate students. And this includes individuals from backgrounds who are underrepresented in the maternal and child health field. So with that, I'll stop there and end where I began. As I hope that you've learned today, the Bureau really is committed in its wide-ranging portfolio of programs, as well as our workforce development initiatives, to improve maternal health. And this is not simply, as I said earlier, to advance the health and well-being of women, children, and families, but as you can see here, to ensure a healthy future for us all. So thank you so much for this time. I look forward to our dialogue.